President Cyril Ramaphosa will officially sign the National Health Insurance Bill into law this afternoon at the Union Buildings in Pretoria. The NHI Bill seeks to transform South Africa's healthcare system to achieve universal coverage. Now, the bill has been met with mixed reviews from the business sector, from medical funders, from doctors, nurses, and general society. But what do we make of the passing of this bill? Let us know at Newzroom 405. We bring in now healthcare expertise of the director of the Rural Healthcare Advocacy project, Russell Rensburg. Russell, good morning to you. Thank you so much for joining us. So, the news comes out that this Wednesday the president will be signing the NHI bill into law. What was your initial reaction? Is this a step in the right direction?
I think certainly, I think it's a step in the right direction. As the Rural Health Advocacy project we established in 2009, we have long advocated for better prioritization within the publicly funded system. And in order to do that, I think we need a series of reforms. And in our view, we feel the NHI presents an opportunity for such reforms.
Yeah, let's talk a little bit about what that means, though, for a rural health sector, right? And I mean, the argument certainly has been made that, well, universal healthcare is a great idea, but perhaps it would be more effective in an urban space. What does it mean for rural advocacy?
I think it's absolutely essential. In fact, for rural, when you look at the health statistics that are released every second year or so by the District Health Barometer, published by Health System Trust, they give us an overview of health service coverage in the country. And of the 38 of the 52 districts within this country can probably be considered rural. And you'll find that rural health provision or health outcomes are considerably poorer than those of urban areas. And it's not really got to do just with the infrastructure, it's also got to do with the living conditions of how people live. And the current system just doesn't respond to that. And here I'm talking about things like that we use universally to track health system performance. So maternal mortality, for instance, is like mothers who die while giving birth. It's unfortunate that it has been trending down over a while, but it's still 3 times higher than what it is in urban areas. And for that, you need very specific responses. Similarly, if you look at coverage on infectious diseases like HIV, AIDS, and tuberculosis, the leading killer in South Africa, treatment completion rates in rural areas is often also slightly lower than what it is in urban areas, where it's also a challenge. And then lastly, we saw with COVID, what the importance of having strong primary healthcare systems. You'll remember that about 108,000 people died officially from COVID, but unofficially, when we use the excess deaths, almost 3 times that amount of people or amount of deaths happened during COVID. And many of that could be as a result of poor and unresponsive primary healthcare services. And I think in order to learn those lessons, we need to start reorganizing our system so that we are better able to do some of the main things that's required of a health system. A health system is not really the infrastructure that make it up. That's a very important component. But the main goal of a health system ultimately should be the improvement of population health outcomes. And for us in real terms, that progressive realization that we talk about in the Constitution didn't really have a measure. And I think with introducing more focused reforms and focused delivery models, we can start charting that path on our journey to greater health coverage for all South Africans as required by the Constitution.
I think we need to really get to the minutiae and I suppose the logistical opportunities that you possibly see. I mean, one of the challenges I'm noting right now, Russell, is the fact that if you are in a rural community, say you live in a community or a village like, say, Katahanyani in the northwest, for instance, right? If you are living in that village, you are about 30 kilometers to the nearest healthcare facility, and I'm talking now about a hospital. How does giving or adding the pool of the work that needs to be done and passing some of that also to the private healthcare sector solve that particular problem? When we're talking about, the uptake of people taking their medications being lower in the rural health community. In rural healthcare communities, you're saying HIV medication and TB health medication compliance is lower. How does the private sector then help when you've got those massive logistical disparities?
I think you break, there's an old adage about how do you eat an elephant, right? And it's generally one bite at a time. But the current service delivery model that we have is not really adapted to getting to people who don't ordinarily come to primary healthcare facilities. So you would remember, like, one of the policies that were released in the build-up to the NHI was this ward-based outreach teams where we had like a combination of different actors to look at both the demand side, better educating people about their health needs, and the supply side, having more responsive primary healthcare clinics. But in the current system, it's very difficult to fund that in a coordinated way or to set plans at the district level on particular outcomes. So I think and rural areas are prioritized in the transitional arrangements of the NHI. So we have an opportunity now to trial new service delivery approaches. For example, the country has actually done quite well, relatively speaking, on expanding access to ARV coverage. We have close to 6 million people currently on treatment. Of those on treatment, more than 90% of them are already virally suppressed, right? But we do have some gaps in enrolling more people. So by being able to contract in, which this bill will allow the public sector to do, we could work with partners that worked on HIV, for instance, like Right to Care or WITS RHI and others, to sort of reconfigure how we deliver services in those places. So you could have much smaller teams being located within the community, being coordinated by a district, and making sure that everybody works together so that you don't necessarily just have to go to the clinic that's 30 kilometers away. You could deploy a small community outreach team supported by a team of healthcare workers to start working on the unique health needs of those communities. That kind of collaboration in the current system is very difficult to do, and we end up running parallel systems. But private isn't just Netcare. Private is also non-state providers. And here we have significant capacity across the country, particularly as a result of our expansion of HIV services. So I think here is an opportunity for us to bring all of this together. You'll also note that medical aid coverage often tracks employment, right? So in areas where there's high employment, you have higher medical aid coverage because medical aid is often a condition of service. In rural areas, unemployment is quite high. So the only resources that are available there are the resources that are funded, and those are publicly funded. There's no private provision. By creating what they call these integrated practices, they create a funding pool in rural areas that can attract private GPs, physiotherapists, optometrists, and so forth to be able to run sustainable practices in those areas because there is now funding available to do that. That's not something that exists at the moment. So I think in rural areas, we have an opportunity to really deepen the pilots over the next 5 to 10 years and learn what kind of service delivery models work best in which context.
Yeah.
And I think it presents an opportunity for dialogue for all stakeholders across the system. But we can have better provision by creating the right infrastructure framework to do so.
What do you say to the criticism that, organizations, for instance, such as the Business Leadership of South Africa have come out and said, well, we're simply not ready to sign the NHI bill because we haven't figured out the funding model of this. And the reality is there's a question around just how government actually deals with particular funding models and deals with funding as a whole. I want to bring this to you. You'd remember this perhaps that in March this year, just 2 months ago, a really big story broke about how health departments in provinces simply weren't spending the budgets that are available to them. A province such as the Northwest sending back 200 million rand, Limpopo 103 million rand, the Eastern Cape 62 million rand that could have gone into those very vulnerable communities and simply was not spent. So perhaps there's something to be said about the concerns for how funding and funds certainly are managed. Is that not a concern?
I think there's always concerns on that. And if things were working perfectly, we wouldn't need the reforms. And I think part of when we start interrogating why that money gets sent back is the categories in the way that they funded, right? For instance, you create a schedule and you get funding for infrastructure spending, you get funding for goods and services, you get funding for central hospitals, and all that funding is allocated to a particular line item. So when they underspend in one area, the way the system works at the moment, unless they can condone it or roll it over, they have to return the funds. And that could be funds that are sitting in infrastructure development, and as a result of delays, they were unable to spend it. But they can't direct that money elsewhere because they're only allowed to move 10% of their budget via environments. And I think that often gets exhausted quite quickly. I think what we have here now, when we talk about funding the NHI, it's a very long-term process. We're not starting from zero, right? These are really existing funding, close to 260 billion rand, that's allocated to publicly funded services. and it tries to fund a cross-section of things with very little sense of how well we can do it. We're sort of just adding funding based on what we did last year. And I think now it's an opportunity to start looking, how do we use these funds better? How do we have better financial planning? How do we start working and organizing that funding in a different way? And we may have different outcomes. These are not things that are going to happen on Monday. I think there's a fair amount of consultation that needs to happen.
Yeah.
There's a next step.
Yeah. So let me ask you this, and I need to wrap up, because you make a point about how these are things that they're not going to happen on Monday, and the president obviously signing the bill into law today. The concern, of course, being the timing of this, and it being 2 weeks before elections. So what needs to be done then? Who needs to play a role to ensure that this does work and timeously before it does become an administrative mess?
I think it's not a rush. It's been 15 years to get it to the president's desk, and has been sitting on his desk for a couple of months now. So I think it's important that this bill gets signed, because it creates the legal framework for the reforms to happen. So what happens on Monday is that we start setting up these committees and looking, and all of these are detailed in the transitional arrangements of the bill. And I think here's an opportunity for us to strengthen some of the things that are uncertain at the moment. But all this does is creates a legal framework for the implementation of the reforms.
All right, let's leave it there, Russell. Thank you so much for speaking to us. Russell Rensburg, the director of the Rural Healthcare Advocacy project, very much in support of the president going ahead and signing the National Health Insurance Bill into law this afternoon.